Hello everyone, thank you for tuning in to this pre-recorded session. My name is Kirsty Giles and I am a project manager within the Scottish Violence Reduction Unit. I'm just going to start the slideshow. My job within the unit is a project manager, and I design and run innovative projects across Scotland to reduce violence. I'm also a psychotherapist. So I share a practice in the West End of Glasgow with two other therapists, and I work with children, young people and young adults around their mental health and well-being, and also trauma. I'm not going to say too much about the unit, because if you've gone to the online live event, you'll have heard from some of my fantastic colleagues. So two people from Medics Against Violence and also Callum from our Brave Heart project. So I'm sure they'll have covered what the unit does. What I will say before we go on is how I see my job, and how I guess both of my jobs sort of merge in to one. We talk about seeing violence through the public health approach, and I think public health is a word that's sort of banded around quite a lot. And the way I like to describe it is that if a family member has a cold, then everybody else in the house becomes more susceptible to catching the cold, but that doesn't mean that they will. And we try and understand violence through the same lens. So if you're brought up in violence or you're brought up around violence, perhaps you're more susceptible to become violent, but it doesn't have to be your destiny. And we try and understand the causes and consequences of violence, of which trauma and adverse childhood experiences is certainly one. My job over the next 19 minutes is to talk about ACES, adverse childhood experiences, and how they impact on my work within the VRU, and also the work that you do in hospitals. I've done my introduction, a wee bit about who I am. One of the things that I'm going to do at the end, if you hang around long enough, is I'm going to have a call to action. So if you're interested, please get in touch with me. My details are at the end. I'd be really interested to hear, if you do the call to action, what you do and how it works. So we're going to cover a wee bit about ACEs and their significance. I've put in, I hope, some helpful theories and tools that you could use within your work. They certainly help me in both my roles. We're going to talk a wee bit about where you fit in, and how you look after yourself in amongst this difficult work. And again, the call to action. So hopefully you can listen in for the 20 minutes. The ACES study, you can look this up and read it for yourself, was done in the late 90s, and it was actually an accident. There was two doctors that were looking at female obesity, and they sort of stumbled across this really fascinating data. And basically what they found was that the more adverse childhood experiences someone experiences between the ages of 0 and 18, the more direct correlation they have to negative health outcomes and negative well-being, negative coping strategies. They split the 10 ACEs into 3 different areas, so abuse, neglect and household dysfunction. And it's important to mention here that, of course, this is not an exhaustive list, and we know that it doesn't include some really important adverse childhood experiences like experiencing racism and a disability, and being from a marginalised population, for example, LGBTQI+. So we don't want to see this list as exhaustive, and far more should be taken into consideration, but for the purposes of the study, these are the 10 ACEs that were looked at directly. So as I said, the more adverse childhood experiences you had, the more at risk you were for all sorts of different things. Some of them I've put here: 6 times more likely to have an unintended teenage pregnancy, 11 times more likely to have smoked cannabis, 15 times more likely to have committed violence, 20 times more likely to have been incarcerated. There's also direct correlations with adverse childhood experiences and cancer and heart disease and diabetes. So we know that we can now potentially predict that if you have trauma in your young years, you will fall into a cohort where you struggle in certain areas in life. One of the really important things to mention here, when we talk about this, a lot of people say, well, of course, if you're brought up in poverty or in a disadvantaged area, you'll have a direct link with poor health and poor outcomes. But the study originally was 17,000 white middle-class Americans. So trauma is not about poverty. It's not poor people over there who take drugs. ACEs is universal. It happens to us all. And if we could try and understand that, then we would get closer, I believe, to taking the perspective of people who fall into the category that's on the screen at the moment. Another interesting point to, I guess, touch on here is a really recent study in 2018 looked at the correlation between adverse childhood experiences and suicide attempts and ideation, and found that someone with no ACEs compared with someone that has 3 or more ACEs, their attempt at suicide increases threefold. So people that come into A&E that have tried to attempt suicide or have suicidal ideation will more than likely fall into the category of having quite severe adverse childhood experiences, and that's important. Most of the people that you work with potentially will have had adverse childhood experiences. People don't come to A&E that are coping well or have a healthy life. So this is where it gets slightly more therapeutic, but I thought this was important to talk about. So Carol Rogers was a famous psychologist and psychotherapist, and he coined the term core conditions as a person-centered therapist. And what he meant by that was that if we can get the core conditions right, which is a way of being in the world, it's not a theory or any academic literature, it's simply a way of being a human being. And he believes that if we get that right and we become people who are in the search for understanding, then we will have a real shot at helping people who have experienced trauma. So he talks about the acronym WAGE: warmth, acceptance, genuineness, and empathy. And he talks about how we should suspend judgment, blame, shame, and accusation from the conversation around ACEs and trauma, and simply ask ourselves, what's going on? What happened to this person? Which is very different to what's wrong with this person. That's what we tend to ask a lot, what's wrong? A far more powerful and healing question is, what happened to this person? And what is my role in it? We believe in the VRU, and I believe as a therapist, that if we do more of this, then we will understand people who have experienced high ACEs and trauma, and we will be far more powerful in both your role as A&E doctors or someone that works in the medical profession, and my role to help stop people from getting to you. The little image on the left we use as a visual of this. So the little plant in the corner has got no sunlight and is not looking very well, and is in isolation or is not surrounded by any other plants. And the way that we talk about this in training is often, well, if you see a plant in the corner of the room and it's not doing very well, you don't say to the plant, oh, you've made some quite bad choices, haven't you? You move the plant to the sunlight and you give the plant some water. And a lot of the time they say you talk to plants and they grow bigger. And it's exactly the same with humans. We will never punish people into a better way of being. All we can try and do is change their environment and help them to connect. Because what we know is that what is broken in relationships has to be fixed and healed within relationships too. People don't heal in isolation. Isolation actually kills, which we know now. This is another tool that I use quite a lot in my therapy, and I use it in my work with the VRU. So anyone who experiences a loss in their life, not necessarily always a person, but if you lose a job or you lose a relationship, and if you lose a person in your life, you go through what we call the stages of grief cycle. And we used to believe that this was a bit of a roundabout, and you came in at shock and denial, and you went through all the stages in a really, nice sort of hierarchical manner, and then you came out and returned to meaningful life. And now we know that it's more like a big knot. And one day you can be in denial and you can move straight into bargaining, and then the next day you can fall back into anger. It's a journey. And what I find really important about this model and really helpful is when I learn it and I'm working with someone who's experienced a loss, and I'm sure people that are in A&E a lot of the time have experienced grief or loss. Giving this kind of information to people and helping them to understand that it is what has happened to them that's important, not what's wrong with them, can be really revolutionary for people. To recognise that anger is a stage of grief and loss, and depression and detachment is a stage, but also so is acceptance and empowerment and meaning. And a lot of the time we take these kind of theories and we keep them to ourselves as professionals. We say, I know everything about ACEs and I know about trauma, but we don't actually hand it over to the people that need to hear it the most. And those are the people that are experiencing it directly. And I think if we can do that a little bit more, then we will give autonomy and we will give choice to people in order to understand that they're not just bad people, and the things that have happened to them are far more important than what's wrong with them. Our words have power. I really truly believe that. A lot of the time we still do say what's wrong with you, and the way that we can make that a more trauma-informed approach is asking what happened to you, and also really interestingly, how did you cope? Because if someone's sitting in front of you, whether that be in A&E or my therapy room or in the VRU, I'm really interested in how you're still here. I'm interested in the strength-based approach. How have you coped because you're still here? A lot of the time we see people that have experienced trauma or high ACEs as being manipulative. I would change that to they're trying to get their needs met. People who have experienced high adversity in childhood feel that the world is unsafe. They fire a lot of the time out of their amygdala, so they are in fight, flight or freeze mode constantly. And manipulation is a way that they have managed to keep their world safe. So for me, they're trying to get their needs met. A lot of the time we hear they just want attention, especially hear that in schools with young people. Oh, they're just attention seekers. Actually, we should be changing that to they're trying to connect the best way they can. They're trying to be noticed, they're trying to be heard, and they're trying to connect in a way that is meaningful to them. We also hear they'll never get over it, or they're permanently damaged. And what we know now about the brain and about trauma is that people can continue to learn more effective coping strategies that don't include addiction or violence, but they will not do that in isolation. They will only be able to learn that from role models and positive peer relationships. And we know that again, if something breaks within a relationship like attachment or connection when people are young, we can only fix that within relationships. We can't isolate them and hope that they get better. The final one, I shouldn't raise the issue of trauma or people will get upset. It's just not true. Talking about trauma without forcing disclosure, we're not asking people to tell their deepest, darkest demons. You're not therapists. I'm not trying to train you to be therapists. But talking about ACEs and trauma gives people the opportunity to discuss it. It normalizes the fact that we all go through difficult times, and actually failing to ask them reinforces our denial that we don't want to know, we don't want to hear it, and that they don't matter. And that reinforces the negative coping strategies that come from trauma. So for me, this is a really important way of reframing how we speak to people and what we think and believe about them. This is another really helpful tool that I use quite a lot when I feel or I can recognise and see that someone is out with what we call the window of tolerance. If they're hyper aroused and they are maybe aggressive or angry or pacing, or they're hypo-aroused, where they are demotivated and quite lethargic and not energized, I try and bring them back into their body. So we call this a grounding exercise, and it's really helpful to reconnect someone's brain and body when we feel that they are they're not connected. So I ask them to tell me 5 things that they can see, 4 things they can feel, 3 things they can hear, 2 things they can smell, and 1 thing they can taste. That tends to bring them back into their body. It regulates them, their heart rate slows down, they start to become slightly more connected, and the prefrontal cortex goes back online. So you can use this in your job, you can use it in your life, you can regulate yourself with these kind of things. Just bring yourself back into your body as often as you need to. So one of the things that's really important is you. And you matter. The job that you do matters. And because of the work that you do as A&E doctors or people in the medical field, and because of the work that I do, we have to look after ourselves. And I love this quote: if you do not make time for your wellness, you'll be forced to make time for your illness. And it tells you to read that again. I work in therapy with a lot of people from the medical profession who are burnt or burning out. I work with a lot of police officers who are disassociated from some of the trauma that they've seen, which makes them really shut down to their family and shut down to the people whom they love. And it's probably the saddest aspect of my job, is working with people who care so much but have not cared enough about themselves. So understand your self-care, understand what that looks like, and please do it. Whether that's a bath with a lavender bath bomb, or it's a Zoom quiz with your pals, since that's all we seem to be able to do at the moment. Figure out what raises your serotonin and dopamine and do more of that. You have very stressful jobs, you save people's lives, and you must look after yourself. I can't really stress that enough. There seems to be a bit of a stigma around therapy still these days. As you can see, I'm not a middle-aged balding man wearing tweed that's going to make you lie down on a couch. Therapy can be very healing. Don't wait until things get really difficult to go and speak to someone, because it's far more easy for me and us to do some work together when you're feeling well enough to actually take on some of the behaviour change things. So please look after yourself and make sure that you've got a work-life balance, whatever way that looks like. My call to action, so please get in touch if you do listen to this session. What will you do differently in your job in hospital to further help people you believe suffer from trauma or adverse childhood experiences? And I'd like to just note here that we are not saying that you should be scoring people. There's a sort of big conversation at the moment around, do we have a checklist and we score people on their adversity in childhood? Actually, the type of trauma doesn't necessarily matter. The fact that it happened matters. And how we help people to recognise that what happened to them is far more important than what's wrong with them. So we're not advocating for counting people's ACEs and bracketing them into a place where they get more help if they have more ACEs. Actually, what we're saying is that trauma really matters, and being able to help people recognise that, of course, if they've experienced that kind of adversity in childhood, it will have a huge impact on the life they have, their health, and how they cope. But more importantly, that things can be done about it, that more positive coping strategies can be learned. So please have a think about the things that I've covered in this short 20 minutes and decide what you will do differently, because I understand the theory and I'm sure you've or I hope you've taken something from this theory wise, but I'm interested in what you do. I'm interested in how this impacts how you behave differently, and probably more importantly, what will you do more or less of to make sure that you're looking after yourself and self-care aspect in your life. We cannot pour milk from an empty jug, And if you want to help people, you have to role model by helping and looking after yourself. So please have a think about these calls to action. Get in touch if you have time. Get in touch with the VRU or my details at the end, and let me know what you've decided to do and how it's worked. So thank you for listening. Thank you for the lives that you absolutely save. My email and my Twitter and my therapy page is there. I love this quote: come back, you fool, separately we're nothing, but together we can conquer the world. And I believe that we need a bow for direction, and we need an arrow for travel. So if we can all get closer together from all the different sort of health and social care sector, and we can try and understand how we do things differently, I think we can save more lives. So thank you for having me. Thank you for spending almost 21 minutes of your life with me. Take care of yourself, take care of each other, and hope to hear from you soon. Thank you.